Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're looking at a disease so rare that most clinicians will never see it. Degos Disease, also called malignant atrophic papulosis. It's an ultra-rare microvascular disorder that can begin quietly with small, porcelain white colored spots on the skin, and then for some patients, suddenly turn catastrophic, affecting the bowel, the brain, and other organs. For decades, the medical literature described it as uniformly fatal. But in 2009, Dr. Lee Shapiro met a 16-year-old boy whose story would change the course of his career. Faced with a patient who was deteriorating rapidly and with no clear treatment path, Dr. Shapiro began reaching out to colleagues around the country, searching for anything that might help. What followed was a chain of unexpected emails, chance connections, and bold decisions that led to one of the first successful treatments for systemic Degos disease. In the years since, Dr. Shapiro has become a leading voice for patients with this rare condition, advocating for earlier recognition, pushing for access to life-saving therapies, and working to build a global community for a disease that once existed largely in isolation. Dr. Lee Shapiro is professor of medicine emeritus at Albany Medical College and has served as attending physician at Albany Medical Center, St. Peter's Hospital, and Saratoga Hospital. A fellow of both the American College of Rheumatology and the American College of Physicians, Dr. Shapiro has been a long-standing leader in the care and study of complex microvascular and autoimmune diseases, including scleroderma and Degos disease. He's the founder and chief medical officer of the Anne Steffens Scleroderma Research Foundation and the chief medical officer of the Degos Disease Foundation, where he has played a central role in advancing research, international collaboration, and patient advocacy. Today, he joins us to talk about what he's learned about Degos disease, how treatment has evolved, and why he believes the outlook for patients is far more hopeful than it used to be. Enjoy. Lee, welcome to the show.
Thank you, Jonathan, very much.
So I'm really excited to talk about this disease that I really knew nothing about until a couple of months ago. And it turns out you're one of the world's expert on it. Can you tell us a little bit about the story of how you first encountered a patient with Degos disease and what happened next?
So it was in 2009, I was referred a 16-year-old boy by a physician who knew that I took an interest in rare diseases and unusual problems. He had seen 3 dermatologists for skin lesions that had appeared over the previous year or two, slowly increasing in number. They weren't bothersome other than the mystery of what they represented. And the 3rd dermatologist told him that he had Degos disease, which he and his parents then researched and found only very depressing stories about fatal outcomes of the disease. So when they walked in to see me, they all looked very glum. And I had to admit that I also was a stranger to this disease. But I told them something that was a little out of character for me because they all looked so glum. I said, don't worry, I'm on the case. And I started researching it. And I had to admit that I couldn't find any terribly optimistic reports either. So this disease in a third or a half of individuals can progress from being simply a skin disease to a systemic one with potentially catastrophic impacts, especially on the gastrointestinal tract and the central nervous system. He had no symptoms when I first saw him to suggest systemic disease. Or if he did have them, he wasn't sharing them. But over the next 6 months, he started to experience bouts of abdominal pain, which became progressively more intense. This culminated in the sudden development of truly intense pain and bowel perforation. When he had surgery, the gross appearance of the bowel showed dozens of lesions that look very similar to his skin lesions. And that's to say that in Degos disease, there are these atrophic porcelain-colored lesions in the skin with a telangiectatic or erythematous rim. And the same kind of lesions were there on the bowel, but larger. The perforation was dealt with. The wound was closed, but he continued to have abdominal pain. And 2 weeks later, he had another perforation and was rehospitalized. At this point, knowing the literature didn't really offer any approach to treatment. There were lots of reports of failed treatments, but none of a successful one. I reached out to those individuals who had publications on Degos, but they didn't really have any treatment to offer. I received comments that one does in such a situation, like, you should send him to Boston. But I knew, since one of those people I was communicating with was at a Harvard hospital, that there was no answer in Boston either. His ischemic bowel was edematous. They couldn't close the abdominal wound, so he was in the ICU with this large open wound, requiring, and he was febrile and tachycardic, and was requiring pressors as well. He was really quite ill. So we had nothing to offer him other than supportive therapy. Until a couple days later, I got up out of bed and I thought, if I don't come up with an answer today, he's going to die. And I did reach out to a doctor in New York City as well, who said he didn't offer any advice to someone he hadn't seen. And so when you have someone in the ICU with an open abdominal wound, that door was pretty much shut as well. So I got up out of bed and checked my computer and found an email about a pulmonary hypertension study, which had nothing to do with Degos disease, but the recipients, and there were about 30, some of whom I knew, had their addresses on this email unblinded. So I thought I could write 30 people who are all clinical researchers, and maybe I'd get lucky and find someone who had encountered the disease and had an answer. So within 2 hours of my writing about the circumstances, 12 of the recipients had responded, and 9 said they'd never seen it, but they were curious, let them know. 2 said they had seen it and their patients had died. 1 had a few treatment suggestions, but he'd never tried them, so I was reluctant to do so. And the 12th was from pulmonary hypertension specialist at Cornell, Evelyn Horn, who was at a meeting in Portugal. And when she opened my email, she was actually having lunch with one of my mentors, Dr. Virginia Steen. It was maybe to my good fortune that I had a character reference right at her lunch table. And so she wrote me back and said, "It's funny you should write. 6 weeks ago, we had near identical circumstances at Cornell, tried a new medication and had fantastic results." But she had to write back to Cornell to get the name of the medicine. She was just the consultant on the case. And New York had to write back to Portugal, and then Portugal back to me in Albany. And that all took only a few minutes. And the email arrived, and it just said eculizumab, which, just like Degos disease, was something at that time I had never heard of, never used, nor had it ever been used in Albany.
Wow.
So I looked up its mechanism of action, called the medical director of the company and that manufactured it, reached her secretary, who asked me if this was an emergency, and fortunately was very perceptive and said, before I said anything, she said, "From the tone of your voice, I can tell it is. I will put her right on." And so I spoke to the medical director and said, I had a then 17-year-old boy who was dying of Degos disease, and I knew they had used eculizumab successfully 6 weeks before, and could I get it? And fortunately, after going through all the precautions necessary with this drug, she agreed to release it. The delivery was delayed a couple days by a snowstorm. This allowed me time to get approval for use of the drug at the Albany Medical Center because, again, they had never used it. But it did arrive. It was infused, and I received a text message from my patient's father 2 hours later, just saying, "It's working." 10 exclamation points. And what he meant was that within minutes of the infusion, his son's pulse had normalized, his temperature had normalized, and they could even see, because of this open abdominal wound, that the bowel loops looked pinker and healthier. And he progressively improved. So that when I saw him in the office a month later, he had been the sit-up champion in his high school, doing 80 sit-ups in a minute. So he looked so good. I said, maybe I wasn't thinking like a surgeon, but I said, "Could you just do a sit-up to show the degree of your recovery?" Which he did do. I didn't have him do 80, just one. And he was smiling and pain-free. So I learned from that. Well, I wondered first how this treatment had appeared at Cornell. The drug was out for other indications for paroxysmal nocturnal hemoglobinuria. And the patient at Cornell just lucked out that the dermatopathologist at that hospital, Dr. Cynthia Magro, had an intense interest in Degos disease for many years previously, and had observed consistently on skin biopsy specimens that there was evidence of complement activation with dense deposition of C5, C9, the complex membrane attack complex in this skin biopsies. And there was also evidence of deposition of MXA protein, which is a surrogate marker for interferon activity. So she had come to the logical conclusion that interference with complement activation, especially at C5, to prevent formation of membrane attack complex, might be a therapeutic approach, as might be anti-interferon therapy, although none then existed. So she had actually walked over to the ICU at Cornell, where the patient there was languishing as mine had been, and said, you really should try this medication, because they had tried a succession of other interventions which had not been helpful at all. And so after several such trips, I think she did succeed in convincing them to try the drug. And the patient, who had been in heart failure and had bowel issues as well, just recalls awakening and seeing about 18 people around his bedside. He was astounded to have that kind of audience, and they were astounded at just how well he looked. And he had a remarkable and I would say near complete recovery as well. And now it's 16 years later since that initial treatment, and he's walking to work, got married, had a daughter, and does scuba diving. So these two encounters, well, the one really I only learned about, although I met that individual subsequently, but also my own experience were incredibly empowering, emotional, going from really the same sense of despair that my patient's parents were experiencing, I was experiencing, because I really felt I had nothing to offer, to going to this cloud of a feeling that spectacular success had been achieved quite unexpectedly. That an answer had arrived at the very last moment by unexpected circumstances. Now, he did well for a period of months, and I thought, okay, this isn't so difficult as it appeared. But after those months, he started to have recurrence of abdominal pain.
So at that time, he was continued on eculizumab?
Yes, he was
treatment?
maintained on eculizumab.
Got it.
And he started also to have the gross hematuria and neurologic symptoms. He'd have episodic involuntary movements of one arm and some dysarthria, very transient. He had a cystoscopy performed, which showed lesions on the bladder wall, very similar to those on the bowel wall, and the presumed source of his bleeding. And he had MRI, which showed areas of abnormal enhancement, MRI of his brain. And I was in the same position I had been a year before, that, okay, he has this ultra-rare disease. I have already scoured the literature, reached out to all the experts. An answer arrived not from one of those experts, but somewhat by luck. But that was the only treatment which had a track record of success, limited as the number of individuals were. And at that moment, there was another stroke of serendipity, that I encountered another patient. She was someone I had seen for some time because she had scleroderma and had developed pulmonary hypertension. But in addition, she had developed very extensive skin lesions, which were not typical of scleroderma, but looked like Degos lesions with porcelain-like avascular appearing lesions extensively on her chest, on her hands, on her legs, also with telangiectatic rims. And a biopsy showed, in fact, the skin changes were consistent with Degos disease. So she went on subcutaneous treprostinil for her pulmonary hypertension. And this, again, was back in 2010 when there were very few options for pulmonary hypertension. she had been breathless walking from one room to another in her house. So she returned to the office a couple of months later, and she was dramatically improved in regard to her pulmonary status. She said she could walk a golf course. It was an incredible degree of improvement. But she also volunteered that her skin lesions had disappeared.
Wow.
And indeed they had, or they were in the process of involution and disappearance. And having nothing else to go on, and having my patient having these repetitive neurologic events, recurrent GI symptoms, and gross hematuria, I thought, well, here is a drug that might be helpful. If it's helpful for the skin, maybe it will help these other manifestations as well. And initially, I really couldn't come up mechanistically with why it would work, but I was able to obtain the treprostinil, and the patient and the family understood that this was really an act of desperation, that we knew the closet was otherwise completely empty. So we started the treprostinil, and within a matter of weeks, you have to titrate the dose up with treprostinil, so nothing happens right away. His gross hematuria resolved, his neurologic symptoms resolved. Again, they were episodic, but there were no more episodes. And his abdominal pain again resolved. So he was maintained on therapy with eculizumab and treprostinil. And I subsequently thought a bit more, reviewed the literature on treprostinil, and found one paper from France, from a hematologist in France, who had studied young girls with idiopathic pulmonary hypertension, and found that they had depressed number of endothelial progenitor cells circulating, and that the number of these EPCs doubled within a few weeks after initiation of treprostinil. And so I thought that this must be the mechanism. Also with Degos, that Degos disease is an angiodestructive process. There are loss of lots of small arterioles, and from these porcelain-like lesions that are characteristic of it, it appears that there's a problem with revascularization, or neoangiogenesis, that new vessels aren't formed. So the doctor from Paris was actually at Boston Children's Hospital for a year doing research on a sabbatical. I contacted him, and he was excited enough to travel to Albany to see my two patients. And we discussed doing a study of individuals with Degos disease, starting treprostinil, to see if we could in fact demonstrate that this jump in number of endothelial progenitor cells occurred and might provide the mechanism for the disease response. Unfortunately, this really proved too challenging. Although the manufacturer of the drug was very interested, this would have been a totally new therapeutic avenue, that it isn't just a vasodilator, but an angiogenic agent. But due to the ultra rarity of the disease, with perhaps 50 cases occurring worldwide in a year, many of whom don't need such aggressive therapy because they have skin-only disease, we weren't not able to conduct that study. And so it hangs there in the air. I can't say for sure that's why treprostinil worked. Now, by that time, we published a paper on the treprostinil. We published a paper about laparoscopy being the procedure of choice for detecting GI involvement, because colonoscopies, which had been previously employed, had often given false negative results, that they appeared normal, and a few weeks later the individual had perforations, not immediately post-procedure, but weeks later. Whereas laparoscopy, in our experience, we never encountered someone who had a normal laparoscopy who went on to get a perforation. So I got a lot of inquiries from really all over the world about management of systemic Degos disease, but I quickly learned that eculizumab wasn't going to be, or even the combination of eculizumab and treprostinil didn't represent an effective answer in everyone, particularly those who had neurologic disease, but did not predictably, very occasionally, as my patient, there would be a response to eculizumab, but in others, events continue to occur despite eculizumab or eculizumab and treprostinil. And then we encountered some individuals whose even their bowel disease didn't seem to respond to therapy with eculizumab alone. So there continued to be deaths. And then, of course, there was the other arm of what Dr. Magro had observed, which was that Degos disease might be an interferonopathy, that there is too much interferon activity. Again, a conclusion reached from her close observation of skin biopsies, and this was a consistent finding, this deposition of MXA protein. And we had approached one of the manufacturers of anti-interferon agents some years before, but drug companies really were not interested in therapy for Degos disease. First, because of its rarity. The second, because it appeared that combination therapy was required. And the third was that there were deaths with this disease. And so if there were a limited number of patients in a drug trial and there were multiple deaths, that would be a black mark on that drug and on the pharmaceutical company. So, but within the space of the last 4 years or so, there have been individuals treated in different areas of the world with anifrolumab or a JAK inhibitor, both of which by different mechanisms can diminish interferon activity. And these individuals treated have been those who certainly would have died in the past, who had explosive or catastrophic character of their Degos flares with often simultaneous neurologic events and gastrointestinal events. And they had striking and almost immediate response to addition of the anifrolumab or JAK inhibitor. So now I feel there are many, many questions that remain, but we are in a new, incredibly promising era when no matter how ill you are with this disease, and often we have to treat individuals who are very ill, who've had bowel perforation, and you don't want to really give them immunosuppressive therapy, but you know that if you don't, they're just going to continue to have events and get into a deeper and deeper hole. So often it's the gutsiest intervention that any of us, those involved in treating these patients, have made, treating someone so ill, maybe with peritonitis, with these immunosuppressive drugs. And we have an awful lot to learn in terms of how intensive the anti-interferon therapy needs to be. From my own patient's experience and that of others, when we initiate these drugs, it appears that individuals have an indefinite or lifelong need, but maybe not with the same degree of intensity that we employ when they're having flares and when they have a very strong interferon signature in their cerebral spinal fluid or elsewhere. So that's the story to date. It's gone from, again, no therapeutic option to now multiple agents, and we're still, because again of the rarity of the disease and our inability to do formal studies, at least in a short period of time, um, that we're still dealing with lots of questions, lots of uncertainties. But I won't say it's an abundance of riches, but it certainly is in comparison to where we were before.
Lee, that is an absolutely incredible story. I have to tell you, in just reviewing the literature on Degos disease, almost always the first sentence of articles states Degos disease is a uniformly fatal condition. And it is just incredible in how gutsy you were initially to say, I think that there could be, treatment options. I'm going to look for treatment options and actually, email people and serendipitously, find others that had treated patients uh, with complement inhibitors and with great success. Um, so, what do we know so far about the etiology of this disease? Is this a sort of genetic driven disorder? Is this some sort of acquired disease? What do we know about what brings this on?
Um, so, in this regard, I need to mention first that we are incredibly fortunate that there is an investigative group at the National Institutes of Health led by Dr. Manfred Bohm, because without them, I think we would be so challenged to pursue this. And so he and his team have they have developed an inpatient protocol at the Clinical Research Center there, and have enrolled about, I think, 20 patients or so, not those who were in extremis when because they couldn't journey there, but individuals with both cutaneous and systemic forms of Degos. And Dr. Bohm is a geneticist, and so they haven't found yet the responsible gene. However, there is one report from Germany where they did identify a genetic marker, which was a gain of function mutation in the interferon receptor. And that young patient, a 6-year-old girl, is one of those. She was, in fact, the very first one treated with anifrolumab and a JAK inhibitor. And she had severe neurologic deficits, but she stabilized, and no further event occurred on that combination. So there we do have a causative factor. The genetic cause is suggested by the occurrence of familial cases, although most are sporadic. So we don't yet have an answer. Dr. Magro has found evidence in a few cases of markers of parvo, that there may be a role for parvovirus. That parvovirus is a endothelial-centric virus that can initiate endothelial damage. But this hasn't been found in all or the majority of cases. So as rare as the disease is, there may be several different pathways to getting there. And I do want to just comment on one thing that you said, that those papers and chapters that talk about Degos as a nearly always fatal disease. Again, the largest slice of the pie, though, of people with Degos are people with skin-only Degos disease. So that's called, so Degos goes by several names. One, malignant atrophic papulosis, which is certainly scary if a doctor delivers that diagnosis to someone. But in those with skin-only disease, it's called benign atrophic papulosis. the difficulty, of course, is people can transition from skin only to systemic, and almost all will present with skin lesions first. It's if they don't, it's almost impossible to diagnose Degos disease. But if someone had perforation and laparotomy revealed these serosal lesions that are similar to those on the skin, we really haven't found, after consulting with multiple surgeons, haven't really found anything that can mimic those. So if someone presents with perforation, has those bowel lesions, then we could say, yes, they have systemic Degos, and it's possible that skin lesions will subsequently appear.
Got it. So the sort of benign or skin limited lesion, limited condition is benign as of now, and those patients could progress to sort of the malignant condition where they have, widespread involvement of the CNS and the bowels.
That is correct. And that's one of the challenges or difficulties of living with this disease if you're diagnosed even with skin only. So about 95, 97% of individuals who will transition to systemic Degos will do so in the first 7 years, the majority in the first 2 or 3 years. I'm aware of one individual where bowel perforation occurred 30 years after the appearance of the skin lesion. So,
oh my goodness,
the risk of conversion becomes vanishingly small over time, but not zero. So the diagnosis of Degos disease, even as a skin-only disorder, as was again the case with my initial patient, is just an incredibly anxiety-provoking issue.
I can imagine. And I guess patients that have only skin-limited disease don't receive any of this treatment, or do they?
They do not. However, at the NIH, they will study individuals with skin-only disease and have turned up, and I have as well turned up individuals who unexpectedly had evidence of bowel lesions who didn't have any GI symptoms. And those individuals have been treated with eculizumab, or now ravulizumab, which has a less frequent dosing interval, to forestall the development of an abdominal catastrophe, which otherwise seems likely. So we don't wait for that catastrophe to occur, because it certainly is more problematic giving these agents to someone who's acutely ill with a perforation and infection. But I have to say that the other issue, I've learned a lot from this disease. And one is the incredible difficulty of accessing drugs that are enormously expensive and are not and don't have an FDA indication for Degos disease. So eculizumab and ravulizumab, maybe it's changed, but they're in the range of $500,000 to $600,000 a year.
Wow.
The other agents employed somewhat less, or a lot less, and it takes an enormous amount of advocacy to get an insurer to approve these drugs. We've been successful in almost every instance because we can educate the physicians at the insurance companies. We start from a position of strength, knowing we know more about this disease than the person we're talking to.
And that's almost always the case,
right,
when you're talking to insurance companies.
And when we can talk about the very high mortality from this disease, it certainly challenges the resolve of the physician at the other end of the phone. Even so, the denials do occur, and I'm aware of one individual in this country who has kind of resigned herself to dying because these appeal letters, which carefully document everything that's in the literature have still failed to sway the insurer. And globally, it's even more of a problem. If in a country with national health insurance, such as England or Ireland, um, when the medical bureaucrat is thinking about what those $600,000 or £500,000 or whatever it may be could do in terms of the number of people, and weighing that against saving one life, um, I can understand the challenge. And we do the best we can. There are many other countries where the issue is that the manufacturer, whether it's Alexion or AstraZeneca, has no presence, whether it's India or elsewhere. So as of a few years ago, Alexion had no presence in India. And I was contacted by someone from India whose daughter had systemic Degos disease. And parents will go even further than physicians in terms of trying to access these drugs. And so he did obtain it from drug smugglers based in Nepal or Pakistan. And there was another individual in Taiwan whose daughter had systemic Degos disease. And he sold his home to finance her eculizumab. Unfortunately, both of those children had neurologic Degos as well as gastrointestinal, and they both succumbed from the disease. Now, even just a few years later, if they had ready access, not just to eculizumab, but also to these anti-interferon agents, I think the outcome would be different. And I have to be very, very cautious because we still are, speaking from very limited experience. But so far, everyone who's been treated with a combination of eculizumab and anti-interferon therapy has responded. There hasn't yet been a death or a disease progression in any of that very small set of individuals, which is no more than half a dozen. So I can't speak of what's going to happen tomorrow, but I can say it's just such a dramatic change from where we were 15 years ago.
Absolutely. And so you mentioned sort of eculizumab and an anti-interferon agent. Are prostacyclin analogs still part of the treatment for these patients?
This is a challenging question for me in particular, because, again, I have a certain attachment emotionally to the use of the treprostinil because it really wasn't discovered by me, but it was discovered by my patient that this was effective therapy. But treprostinil has several challenges. First, it doesn't work right away, and that's certainly the case with pulmonary hypertension. That it takes weeks or months to have maximal impact. But that's definitely the case in Degos disease. That if someone's in the ICU with a bowel perforation, you don't have to rush to start treprostinil because it's not going to change their status in the course of a week. Whereas the eculizumab and whether it's a JAK inhibitor or anifrolumab could have an impact with remarkable rapidity. But that said, that very first patient who was treated at Cornell, not by me, who received eculizumab with dramatic results, then developed a persistent wasting syndrome with persistent gut dysfunction despite the ongoing eculizumab. And he was maintained on total parenteral nutrition for
Mm.
several years, and then he was referred to see me. And yes, in the realm of Degos, I've acted what is for me, I guess, very out of character as far as. So I said, well, I think this bowel dysfunction is probably related to devascularization from the disease, um, which the eculizumab isn't helping. At the time, we didn't have anti-interferon agents, and I don't know if that combination would have made any difference. But I suggested that we add the treprostinil, and I can't remember if it was within 6 months or 12 months. He was able to stop the TPN, and he remains on this combination of treprostinil eculizumab, and again, it's well more than a decade later. So I think that the treprostinil. So this disease again has this the systemic disease has this component of intense activity of the complement cascade and of interferon interconnected, but there's also damage. And so the treprostinil may speak more to the damage component as far as promoting revascularization. It's not a therapy, again, that will help in the acute situation.
Amazing. And you've been, in addition to treating patients with Degos disease, writing very important articles about sort of the treatment of these patients. You've also been an advocate for patients and to increase research. I think you were the co-chair of what was called the first international symposium on Degos disease at the NIH, and you've been working with the Degos Disease Foundation. Can you tell us a little bit more about sort of your advocacy work in trying to, improve knowledge about these conditions and improve treatment?
Yeah, so for this disease, they don't really teach you much in medical school about advocacy, or at least back in my day, they didn't. But I
They still
realized,
don't.
I realized in this disease, it's all about advocacy. And so first, it's of course advocating for yourself in terms of which, so people don't, feel that they have a shepherd for dealing with their disease. And so I somehow, again, out of character, I put myself into the role of the shepherd for that first patient, even though at the time I knew nothing about the disease, but I recognized that the first intervention had to be dealing with the patient's and the family's anxiety and just sending them out with some hope. And that's still the case kind of universally in every individual who receives this diagnosis. The initial reaction, especially if they go to the literature, is intense anxiety. So one way of coping with that is we're trying to get into the literature, which means we have to finish writing the paper, is getting a paper on a review of long-term survivors of systemic Degos disease, which we are undertaking. So it'll be an account of nearly 10 individuals who are greater than 5-year-long survivors, so that there's and again, the first one treated is still doing very well 16 years out from initiation of therapy. So we want to get a positive story there. So it's not, again, you read these papers and you just have gloom. And the other thing is through the website, degosdisease.org, that there's a community, so that when individuals, the woman who started it, Judith Calder in England, when she was diagnosed, she felt she was the only person in the world. There was no one else in England there was, and she developed this website, which became the hub, not just for patients and their families, but physicians seeking information. That has grown over time, and there are about 300 individuals who are members of that community now. But the stories are very sad when they are stories of individuals presenting with catastrophic events, bowel perforation, or uh, catastrophic neurologic events, and they weren't diagnosed as having Degos, or if they were diagnosed, nothing had been done in terms of disease evaluation. So we've thought about this, and so the other part of advocacy is making sure that Degos disease is recognized, and we felt the greatest impact would be with dermatologists, because there are many stories of individuals who've seen. Dermatologists are the ones who ultimately make the diagnosis in the vast majority of cases, but they may have seen one or two dermatologists before they get to the one who actually makes the diagnosis. And they may be misdiagnosed with other much more common skin disorders, which really don't look just like Degos. The most common one, misdiagnosis, seems to be molluscum contagiosum, which has nothing to do with Degos and doesn't really look like it, but it's common. So, so we're developing programs for. We hope to be able to develop a session at the American Academy of Dermatology to tell dermatologists not just what the lesions look like, because those who know of it know what the lesions look like, but to change their mindset a bit so that they know it is now a treatable disease, and also to tell them what is the appropriate workup if someone has cutaneous lesions of Degos. So that's another part of advocacy, education. But the third part, as I mentioned, is getting access to the drugs. That's a lot of work, and getting drug companies interested in Degos disease. And so how can we do that? Well, as it turns out, from my second patient, I learned Degos disease and scleroderma can overlap. And it turns out they went through every one of their in the scleroderma clinic at Stanford, about 500 people, and found that 25% of those 500, or 5%, had Degos-like lesions. And
no kidding.
And that population was enriched in those with the most severe microvascular disease. Whether it was pulmonary hypertension or recurrent digital ulcers, or other manifestations of the microangiopathy of scleroderma. And Degos disease can also overlap with dermatomyositis. And I hope to pursue further whether there's the segment of people with dermatomyositis who get bowel perforations are the same individuals who have Degos-like lesions. So there is perhaps a two-way flow between that what we know about Degos may inform what we know about scleroderma or dermatomyositis or lupus, where Degos-like lesions can also occur, and the reverse, that agents that are developed for these more common disorders. And again, if you're from the world of Degos disease, you think of dermatomyositis as a common disorder.
To put things into perspective.
Right. So the advocacy is really advocating really this campaign against anxiety, and introducing hopefulness, and then really advocating for education so that it's identified, and then making treatments, not just developing new treatments, and learning what the best treatment would be, the minimal effective interventions, but getting access to the drugs. And it's going to differ in every country, unfortunately.
Amazing. And looking ahead, what do you hope to see, over the next 5 to 10 years regarding, research on Degos disease? What sort of questions do you think still need to be answered?
Well, it would certainly be nice to develop tools to predict who is going to evolve from cutaneous only to systemic Degos. Will some change in the interferon signature lead us to that, or some other serologic marker tell us that? Also, that we will refine our knowledge, slowly accumulated, of just what the best regimen is. And new drugs are appearing all the time. So again, 15 years ago, Dr. Magro knew that anti-interferon and complement inhibiting therapies should be helpful, but they didn't exist, or they were just coming into existence. So even with that knowledge, it was really impossible to intervene. Now, these drugs are multiplying. It's really a challenge keeping up with what is available there. But we're also going to have to learn after these events occur, and we have to throw so many powerful drugs at an individual. Is it possible to lower the intensity of the treatment, both from a safety and a cost perspective? And I hope that we will find, which we have in just a smattering of cases, the one I told you where the gene mutation was identified, that we will, there may not be a single answer, but we will identify the cause. So I think the next few years are going to be incredibly exciting and encouraging, and that the dark phase hopefully has passed. Unfortunately, there are always going to be individuals who present with catastrophic events because they were not diagnosed, and may not be the doctor's fault. We want to make sure it isn't the doctor's fault, that dermatologists really have it at the top of their mind and recognize the significance of it. But it might be the individual's not fault, but the nonchalance that these lesions are usually asymptomatic. They're not on their face or hands, so their spouse or friends aren't going to say, what's going on with you? It's hidden, and so not exactly sure how we will deal with that. But we're coming to an age where, okay, even if they're diagnosed after a catastrophic event, there is hope for them. It doesn't matter how sick they are. There seems to be reversibility, and so my feelings about the disease have evolved completely, and it's been certainly the most exciting. Encountering this disease has been the most challenging, most exciting, and energizing event in my career.
Lee, I mean, this has been amazing. I mean, this journey that you've had with Degos disease, from that first patient that was sort of at almost dying, and how you were able to help him and reaching out to others to try to better understand the disease. Everything you've discovered and your advocacy work to try to increase the knowledge about the disease, to collaborating with others to try to better understand the disease, and helping patients, as you mentioned, sort of deal with that anxiety, that and you're giving them hope. You're giving physicians hope, and certainly patients hope that this is no longer a uniformly fatal disease like the articles used to say. You really changed the face of the disease, and it's been amazing to learn about it, and thank you so much for sharing that with us. We'll have links to the Degos Foundation website from the podcast notes, so that people that are interested can learn more and reach out. Anything else you want to tell the audience about Degos? Any requests or advice that you have for us?
Well, to the community of rheumatologists, I would say look for these lesions in individuals with more common diseases, with scleroderma, with dermatomyositis, and lupus. And there's a lot yet to be discovered in terms of what the significance of those lesions are when they appear, because that is what rheumatologists, that's the setting in which rheumatologists are most likely to encounter it. And they are there. Again, I think that all of us may go on similar journeys with other rare disorders. That's part of what makes rheumatology so exciting, and that our patients are incredible in their strength in terms of rising up to these challenges. But beyond that, although they are always a source of questions, just that we should all recognize that they can also be a source of answers, and they have been incredibly helpful.
Well said, Lee. This has been an incredible conversation. Thank you so much for your time, and hopefully in the future you can give us updates about what we've learned since this episode. So thank you for your time, and thanks for your advocacy for these patients.
Thank you, Jonathan, so much, and thank you, Joe, for your technical support. Thank you.
My conversation today with Dr. Lee Shapiro offers a window into what rare disease medicine often looks like: uncertainty, advocacy, and a kind of creativity that doesn't always show up in textbooks. Degos disease is still a serious and unpredictable condition, but as we've heard, the landscape is shifting. However, there's a lot left to be done. After we recorded the show, Dr. Shapiro sent me an email updating me with the story of the 16-year-old boy whom he first cared for in 2009. In his email, Dr. Shapiro says, "He survived for 8 years, most of which were joyful. He worked in our office, fell in love, got engaged, attended PA school, went fishing, boating, and swimming, managing all this despite treprostinil infusion pumps and continued eculizumab infusions. But his disease did ultimately progress in other ways. He developed constrictive pericarditis and pleuritis. He had pericardial stripping and was on ECMO for 2 months. He died shortly after returning home from multiple pulmonary emboli." It's a stark reminder that even with the progress made in this disease, Degos remains a formidable condition. And the story highlights the urgency for continuing to push the science to discover novel treatments and improve the care of patients with Degos disease. If you'd like to learn more, we've linked to the Degos Disease Foundation in our show notes. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. Show notes for this and all other episodes can be found at acronair.org, on Apple Podcasts, Spotify, and on your favorite podcast app. Until next time, keep doing the work that changes lives. And of course, stay healthy.